So thank you, everyone. There's a QR code up there. So if you actually want to submit your questions or anything, then hopefully we can ask the panel to address those a little bit. I just want to pick up a little bit on what Leah said about the research. So in recent years, there's been much recent research and innovation in robots and smart technology with a view of actually supporting day-to-day activities. Now, once again, what Leah actually said is that the inspiration for this arose from some recent research that led to the development of a framework for cohabitation with robots and smart technology within the built environment, so the home, that focused on those living with frailty. So, however, whilst we talk and think about what cohabitation with robots and smart technology in older age may look like, currently the integration of especially robots, excluding those robotic vacuum cleaners, within the home is yet to be realised. So as we explore further how technological advances such as robots may support ageing in place, we need to consider whether this really matches the needs, wishes, preferences of the resident and what the cohabitation may look like in an actual home rather than lab or simulation. And when we're thinking about assistance, we're thinking about assisting those who may have comorbidities, including cognitive impairment or frailty, to enable the resident to age in place. But we also need to think about how and whether these advances might be used to enhance quality of life, and not only as a substitute for in-person support to fill shortfalls in that support. So with that, I'd like to welcome our panel and that come from a range of disciplines to give their perspectives on the topic. So if you could please introduce yourself. Let's start with Jill, who everyone knows very briefly, and then go along.
Okay, so I'm going to change what I was talking about. Now I'm talking about people with dementia and robots. So a couple of years ago, or maybe 3, an excellent MSc student did with us a systematic review of robots and dementia, and found that despite what people said, there was really no evidence that they were at all helpful. They might be helpful, but there was no evidence that they were at all helpful. And I thought that was very interesting. There was some evidence that if you take them into care homes, that people quite liked them, that they were feasible to have, but then they put them in the cupboard and they weren't used. So somebody talked about multidisciplinarity before. So one of my friends said to me recently, you must be delighted about how great robots are for dementia. And I said, I don't think there's any evidence that they are. And he said, well, it's very interesting because we've been giving venture capital to this guy with the robots. Why don't you, this is how people like this talk, why don't you just jump on a call with him? So I jumped on a call with him. And now we are we're in people's homes as we talk, trying to find out if people with dementia like them and if they're any use and what they're any use for. So LEQ, she's called, is quite sweet. She sat in my office for quite a long time while we waited for ethics committee. I unplugged her. She drove me insane. When I wasn't talking, she would talk to me. So I unplugged her because I spent a lot of time not talking but typing. But I'm hoping that for people with dementia, that she will help people who find it difficult to initiate and to go from them. But I don't know yet. So we'll hopefully go in future. But I'm really interested in everybody else's robots.
Brilliant. So we know Jill. So if we now, but we don't know the other panelists. So if you could go through introducing yourself and the area that you come from before we do that key question about integration.
Okay, hello everybody. My name is Paul Neidert, and I'm a biostatistician at the Medical University of South Carolina in the United States. I'll be honest, I really don't know a lot about robots. Okay, but what I do know a lot about is research design. And so I want to bring that perspective here today. I've been involved with biomedical research for about 30 years now. And I became interested in aging research really early on in my career when I was kind of asked to take on the role of a leader of a study that had it was called the Charleston Heart Study. It was a study. The study began before I was born. So the study began in 1960, and they enrolled people who were like 35 years old at the time. And then we've been studying risk factors for mostly heart disease, but other diseases as well throughout their life. And it was during this time of really getting involved with this study where I met Dr. James McNally, who you heard from earlier. And that's kind of my connection, how I came to be here today. And I also, in this process of working on this large cohort study, I hooked up with a group out of Cambridge called the Emerging Risk Factors Consortium. And if anybody here is involved with that, I'd love to talk with you later. But it's a consortium of studies all across the world, probably over 100 different cohort studies. And because of the vast numbers of patients that are involved, we can answer some really interesting questions. And I'll stop with my introduction. Turn it over to you.
Good morning, everyone. I'm Bernadette Lee. I'm a doctor. I've been a consultant in palliative medicine for 20 years. I work at Princess Alice Hospice. It's in Surrey in UK. So my specialty, we get referrals from age 18 onwards. Most of my patients are elderly. They've got cancer, which is no longer curable. Many coexisting diseases. Some of them have dementia, heart disease, lung disease, kidney failure. So they have got loads of medications to take. Their conditions are unstable. And we have to, myself and my team, we need to intervene quickly when they call for help. Most of our patients are at home. At any one time, we've got 1,000 patients living at home or in care homes. And they want to stay at home as long as possible, avoid hospitals. But sometimes we put in the maximum amount of care, district nurses, carers 4 times a day, overnight sitters, and that patient and family, they're still struggling. So we've got the inpatient unit. Thank you for the slides. That's our hospice. We are an independent charity. Because I've worked there for 20 years, I've been involved when we closed down the ward for 18 months, totally redesigned it. So every room is now single room. Everybody's got level access into the garden or the courtyard. We went to visit nursing homes with the dementia wing, and we've put in solid colors for the doors and the toilet seats so that the people can recognize those easily. Thank you, Leah, for inviting me. Thank you for sending your MSc Medical Architecture students to view our hospice every year. What I know, we don't have any robots in the hospice. So what I know about robots in healthcare so far is the four main uses. A very good use in surgery. There are robots that clean hospital rooms. Our local hospital pharmacy, has a robot that stocks the shelves. But they did run into trouble when the robot wasn't working and patients couldn't be discharged for several days. There wasn't an engineer to come. And then there are some places that use social robots. I'm here to learn, because there's a workforce crisis, there's aging population, reduced fertility rates. So any innovation ideas are welcome.
Good. Well, hello everyone. I am Rosa Urbano Gutierrez. I'm very happy to be here today as well. The topic is also new to me. My background is architecture. I'm an architect. I have practiced as an architect, but I'm also an academic. I'm a professor of architecture at the Manchester School of Architecture. My field of research is specialist environments. I'm very interested in how technology and environmental design produces design, generates design, and in particular, I'm very interested in human-centered design. And lately, I have been working a lot on projects related to health and well-being in relation to neurodiversity, biophilic design, and hospital design. But even though I'm very interested in technology and materials, it has always been in relation to how we design the spaces and the environment, but not so much, well, not at all until this opportunity. I have ever thought about robot-inclusive design, what that means, and what certainly we don't teach that in the School of Architecture right now. It's not part of the curriculum. And there is not, I haven't seen anything in relation to standards or regulations. So if this is coming, this is also, very exciting for me to learn how we are going to be dealing with this and what part architecture is going to play in this challenge.
Brilliant. Thank you very much, first of all, for inviting me. I'm just coming from down the road and I keep it short. I'm Helge. I'm a roboticist, and in my lab, we develop the new hardware for the next generations of robotic systems. And we focus on inherently safe systems. And how we do it, this is that we use different type of materials, soft materials, to fabricate our robots so that they are inherently safe in physical interactions. And I believe that many of the users in this field would like to have a physical interaction with a robot at one point, so that we can provide and ensure the user that they will be having safe physical human-robot interactions. Thank you.
Brilliant. So as you can see, we've got a very, very multidisciplinary panel from a roboticist, architect, clinical, biostatistician, psychiatrist, academic. And so we've got this huge disciplinarity. So starter question. What for you are the main issues or points to consider to facilitate actual real world integration and use of robots and smart technology in the home of an older person? And if we target and focus on older age, is this the best way to support integration? So if I can start with you, Paul, that would be great.
Okay. So I want to take off on a tangent for a minute. I want to tell you a little bit about two studies where I think there's some lessons learned that could be applicable to the use of robots in the home. So let me start with this first slide. This has nothing to do with robots. This is a study that I was involved with. It had to do with colorectal cancer screening. And this we published this back in 2010. So it's a 15-year-old study now. And back then, we knew that colorectal cancer screening saved lives. So we knew we had this technology that we could use to, help people live, longer lives and disease-free lives. This particular type of screening is unique in that you can actually prevent the disease during the screening process itself. During the screening process, they can remove polyps that can ultimately develop cancer. So at the beginning, it was about around 60% people were up to date with screening. And our goal was, how could we increase that? And my point here is, how do we do it? Well, it involved this theme. It's funny because I came up with all this, and then I didn't realize that one of the biggest themes here is about interdisciplinarity. And to get our numbers up from 60% up to 71%, it took a lot of work. And it involved people from the research team itself was comprised of physicians, nurses, me as a biostatistician. We also had database management, computer programmers involved. to come up with a solution. The solution really came from the physician offices themselves, but it really didn't come from the physicians. A lot of the input to make these improvements came from the nurses and the front office staff. And so some of the best ideas came from people that you might not expect, would develop the solution. So our front office staff, they said, well, why don't you just give us the ability to order this on the patients, and then kind of remove the physician from the process altogether. And that ended up helping a lot. I personally was making some graphs, and I all of a sudden realized, wait, we have some problems with the 50-year-olds and the 51-year-olds. And I was able to get them to start focusing on the younger people, because they were that's when you start needing a colonoscopy, is when you're 50 years old. And so we all bring this different, having multidisciplinary approaches really helped us make improvements, but it really did take a lot of different types of input. So what does this have to do with elderly patients and robots? I think we can have wonderful tools and that we think are going to improve people's lives, but to really make this happen in the real world, it's going to take a team effort. And also, we shouldn't assume that just because we have a wonderful technology, that it will improve health. And if we ever are going to maybe insist or hope that some of this kind of technology will be publicly funded, by, say, maybe in the U.S. by Medicare, or in the UK by the health service or something, that we need to make sure these things are safe and that they are effective. And again, this idea about having multiple stakeholders, I think, is going to be really important. Now, let me show you another slide. And yesterday I've met at least 3 people who were musicians. So do we have any musicians in the audience here? I see a handful. Okay, good. So this is results of a study that involved some patients that have Alzheimer's disease. And the study was all about to see if we could use music to improve their health. Now, we were using very short-term approaches. We were looking at outcomes like how alert they were, and overall how was the music affecting their general well-being as assessed by the physician. And so the clinicians came to me and said, how can we design this study? So the answer was to use I would call an innovative clinical trial. It's called a crossover trial. So if anybody, a lot of you have probably heard of randomized clinical trials, but what makes this special is that each person receives both the intervention and the control condition. So in this particular study, our control condition was the patient just listens to nature sounds. So maybe just sounds of birds or crickets or things like that. And then the intervention, arm, and during that part, they listened to their favorite music. And so the caregivers were involved with this. They helped to figure out what the person's favorite song was. And you might be thinking, how do I distill music down into these graphs here? How did I do that? Well, what we're looking at again is how does the music affect these people? And on the left panel has to do with the alertness. The bottom line is this was a very small study, but we had extremely significant results. And when I'm a statistician, so when I say significant results, that means we had very small p-values. But basically, the patients were way more alert when they were listening to music compared to when they weren't. And the physicians agreed with that, and that's what the right-hand panel is saying. And again, you may say, what does this have to do with robots? The first thing I'll say is that music affects our brains in fundamental ways that we really just don't understand. If anybody is my generation, when we used to listen to music, we would listen to an entire album often. And if you're old enough, you remember that if at the end of one song, it might end, and then all of a sudden in your mind, you can already hear the next song. and I think the young kids today don't have that same experience because they're always just picking one song off of an album at a time. But maybe I'm wrong. But obviously, music has to do with these connections that are going on in your brain, and I have the sense that the people that are caring for patients with Alzheimer's, like in this case, they've known this for a long time, that music benefits their loved ones. So I think about if we're going to get any input on new technology, we want to get input from the patients themselves, their caregivers, and also perhaps robots should incorporate music. I think I'll leave it at that.
Okay. Do you want to address that, especially with the music aspect? And
so I like to pick up Paul's comment and example of colonoscopy, and I like that he is saying that they are in order to address it, and a 10% increase is over that time period is impressive. I think it is important to involve everyone in the chain, in the flow, healthcare flow, to involve all of them. And sometimes the entire team understands where the real problem sits. In my bubble, in my community, robotics community, there is a lot of emphasis, for example, in colonoscopy, on the technology and to robotize something like a colonoscopy. And I think that the bubble sometimes forgets that one of the major problems is actually preparation. Those of you who have undertaken colonoscopy, you're laughing. It's not that funny, I think. But those of you understand what the burden is to actually go and have a colonoscopy, right? And there are not many that I know of that address that problem, because I think if you address that problem, maybe you have even more success rate there. And so what does that tell us? That we might also need to ask the patients who have undergone colonoscopy to give some feedback on what should be developed and where the bottleneck is. And I think that means for our debate here, or panel, that we also need to involve the people, the elderly people, to really understand what do you want? What do you accept in your life? Is it a robot that can talk to you, or is it some physical interaction that you seek, or you do not want to have that at all? So involving them, as well as, unfortunately, the business people, because somehow this has to be financial viable in our community. I think these are also areas that we should involve in our debate if we are looking into developing technology, robotic technology for elderly people.
Brilliant. So, Bernadette, can we come to you? Because you work with patients day to day. And how do you think that robots and smart technology at that stage in your life would be successful or not successful in terms of integration?
I think more work needs to be done. I'll tell you a bit about my patients. There's a lot of apps and technology information on the internet. So for cancer, the biggest fear is cancer pain. And I say, actually, 3/4 have pain, 1/4 don't have any cancer pain at all. The biggest symptom in cancer is fatigue. And all the other illnesses, they come with fatigue as well, heart failure, kidney failure. So they have the apps. For example, my cancer patients, I need to know whether they're going to have any more chemotherapy, so I know how to look after them, what to plan for them. They have difficulty logging into their hospital app. Once they do it, they just hand it over to me. Then I can read all their clinical information, the blood results, the scan results. So they can't engage so much with the technology anymore. And then there are the human factors. We have a multidisciplinary team. When people are getting more frail, we can do home visits. Our physio will and our occupational therapist will assess the home environment, advise them to have a grab rail and a hospital bed. But there are human factors. They don't want change. They don't want their homes upset. And then another, we've touched on this already, so equity. in the UK, we have the NHS. Every year, we need an uplift just to maintain the services. And we have to fund new medicines, new technologies, new surgeries. So how are we going to, if there are successful robots that can be used in the home or the care home, are we able to have these robots? And then I want to mention sustainability as well. We need to use all our resources so that they're not depleted for the next generation. And the robots, when there are upgrades, what do we do with the current robots? Do you install a new robot in? Yeah. If the robot is not working, can we call someone quickly? So for my patients, we have a 24-hour on-call system for doctors and nurses. There's always advice, and we've got hospice at home night scheme, so they'll go in twos to visit patients. Those are my points. Thank you.
So as we can see from one of Bernadette's slides here, that real world is messy. So now if I actually go to Rosa from an architectural point of view and integration in an actual home, how do you think that will work?
Well, I think it will be very challenging. Well, I mean, I'm not so up to date about what a robot actually needs, but when I was reading a little bit about it, is from a design perspective, is like about allowing enough width in corridors for movement, for the flow. It's about considering the surfaces in terms of material finishes and textures and colors. So how do you provide, considering that the robot has sensors and needs to observe the wall around it and make decisions about that, how do you design the patterns on the floors? How do you differentiate between floor and walls? That is important. It's important because this is the way it's going to be communicating with the surroundings and moving around. If I'm getting it all wrong, and it's about visual and auditory environment that doesn't provide too much noise so that the robot gets confused. So I think on one hand, as a designer, that can be very interesting because you can control that in particular ways in which you might say, by using different textures or colors or patterns, I can create areas that are more private or more public, and the robot can understand that, or different functions for different areas. And that might be easier to implement in a public building, in a hospital, or in a hospice, or however, in homes. And I mean, if I think about the UK typology of home, which which prioritizes terrace houses, or with the stairs and lots of different levels, and I think it can be really challenging. For that, maybe Helge can tell us more about how advanced. So I don't know to what extent we have to preserve the home as it is, because this is what the elderly actually want, and it has to be the robot who gets to be flexible and adaptable. Or if we can, from an architectural point of view, we can do more. I think at home, retrofitting homes can be really challenging.
Do you want to?
Yeah, maybe I pick up Jane's point there, and I think you're absolutely right. Rose, I'm very sorry.
No, it's fine.
I feel a little bit like when Bernadette and Rosa are talking, I'm responsible for delivering the first robotic systems to their home, and this has to be very soon because it's urgent. But that's only my impression. So. But Rosa was saying very good points there. I think there are so many different levels of the environment where people are living. Some people live at home. They want to live at home. Some people are living in your accommodations, which are more maybe uniform throughout. Maybe also between different hospices, they are more uniform than people living in their own home. Sometimes in the UK you have different flooring. So let's describe it as if it's an extreme environment that a robot needs to move in. So there are a lot of challenges, technical challenges, perception, sensing, where does the robot go? And then there are, of course, humans in the room. And sometimes it's not only the human who needs care, but also someone else, which can be a relative or a caregiver. So it's really an extreme environment that the robot needs to operate in safe. And this is not only for the safety, of course, of everyone in the room, but it's also for this trust that the human who needs care needs to go back to the device and demand support. And I think I would even go further and say that a system should not only give support to the caregiver and to the person who needs the care, but a system that you envisage or think of implementing into someone's home or in a care home should really augment the care that is given to the user, not replacing the caregiver, and motivate, in fact, the caregiver to do the daily job, because it's a job that I believe is not really valued in our society to the degree it should be valued. And so to motivate people to choose a career in that field through technology might be also an opportunity, I think. Now, coming back to the technical challenges, one might say, okay, the robot has to adapt to the environment. We're not going to change the environment. I think that both have to come together in a way because of the financial point as well that is playing in the background always, that there needs to be a first version of systems that can operate in the majority in homes, if it's a care home or at home where the elderly person prefers to live. It's very much similar to the vacuum cleaners that are moving around flat surfaces and not able to climb up, or they always come downstairs, but then they will not go up again. But you see, it's very equivalent. You need to have a system that works in many homes, and therefore it's very essential to talk about different stakeholders to understand what can be done with the minimum amount of investment into homes to provide the infrastructure that is required for a system. And then, of course, on the other side, you need to look into what is the key challenge when taking care of a certain community of elderly people, what really can make a difference for the people that need the care and for the people who provide the care. So if they are all coming together, I think then you will have a first solution of a truly robotic device. So I'm not talking about a social interaction where you only have a physical, a passive appearance that doesn't really interact with a human. But if you are talking about a truly physical interaction, I think that is a first requirement to involve the people who are designing homes, who are investing in changing the infrastructure in the home, and as well as looking at emerging problems that can be addressed with a system.
Brilliant. So, Jill, did you want to say a little bit more about robots and dementia care at all?
Yes, I thought so. I thought I did, really. The number of people that we expect to have dementia is such that in some countries, if it would be predicted that the whole of the workforce that is coming on stream will have to look after them. They won't to have enough. So I think it's really important to try and think what you can do, because obviously not everybody is going to be a carer. So what can you do to make a difference? I don't think a robot is ever going to do it all. And I don't think a robot should do it all. I think people need human interaction. But if they can do some of it, I think that could make a huge difference. So this robot that we're trying, and we don't know if we're trying, and I think if we do it, we need randomized controlled trials with health economic components in the end, because that's the way that you can get things into practice. But it costs so much to look after people. You can, if things work quite well, to do a bit of it, save money. So I think we just have to think, well, what do we want them to do? So this robot will play music, as you said. It will play your preferred music. It will remind you about things. It will it will offer you an exercise thing, and it remembers. It's got AI. It will, if you like this exercise, it will keep doing the same things. It will show you art galleries. It will do and it chats. It will do all of these things, and it really, really doesn't mind if you ask it the same question a million times, which families do. They really get very. It's very, it's extremely stressful if people keep asking the same question over and over and over again. So I think, but we'll see what people tell us about it. I think it can be quite good. I tried it with my grandson, who's 3, to see how he would do. He screamed at it, play Taylor Swift, and eventually it played Taylor Swift. But it took some time. It asked you to choose categories. It had quizzes. It told jokes. He liked the jokes. It had categories of music. He didn't understand that. What would you do? But people with dementia probably would understand. This is the category I like. And it asked quiz questions. If you wanted to quiz, for all the quizzes, you had to be old enough to remember the 60s to answer any questions. I think there is a huge potential, as long as we understand. We have to think about what the outcome is, and we have to think about the cost, and we absolutely have to not think that robots are going to be instead of humans. They might be instead of a little bit of humans, but like you said, they're going to augment generally. But we probably need a bit of augmentation.
I'm just sort of thinking, I'm picking up on the fact that you mentioned about the style of communication, which was oral. And I just want to bring in Bernadette at this point about when you're older age and with various conditions, that may not always work that effectively. So have you any views on that?
Yes, so we've looked after patients with neurological diseases, so the motor neuron disease. They can have a bulbar involvement that affects their swallowing and the voice. So our speech and language therapists give them different techniques. They can write, they can use a whiteboard. And a common question that comes from my cancer patients towards the end. So why has my voice changed? I can't speak on the phone anymore. And I explained to them that the normal way that we speak with, propelling air through our vocal cords, even that is weak. Yeah. So if we rely on voice-activated controls for the robot, for your requests, would the robot be able to adapt to that?
Can I just say that it's either voice or you can type in, but they might not be able to type either. But it's not just voice.
Mm. And so I'm just sort of going to go to our roboticists at the end. Should we, in terms of integration of robots within the real world, within homes, should we be focusing on older age or those in rural areas that may have the greatest needs in terms of remoteness? And does that cause connectivity problems? Or should we age into robots? What do you think?
I think that when you look at developing a system for elderly people, you should focus on on challenges that would benefit most people. And this might not be always only the elderly people. It might be, I think Jill, is that correct? Jill was saying that it might be also involving the caregivers. By repeating over and over again the same thing can have mental impact onto the caregivers. The same with lifting up people. If you lift up on a daily basis, I don't know how many, 10, 20 times 60, 70 kg, it will stress your physical body, and then you have people going into rehabilitation, taking off work. You need to compensate for this. So all of this has also an effect of the entire ecosystem. So I think that there needs to be involvement of the people who are actually working there and identifying what are the challenges that needs to be addressed in order to help most of the people. And that will be then viable, I think, to develop a system. And I fully agree that this might be not a system that is doing the entire procedure autonomously, completely, so that no caregiver needs to be there, but you need to leave the robot assistant their bubble that they dream about the full automation. Otherwise, there's no pushing the boundaries of a robotic system and making that affordable for the system itself, the healthcare system. But I think that needs to be done. If that's in a rural area, then it's in that area. If it's in hospice, then it's there. But I think that that needs to be decided. What are the most benefits of a system that would be then developed for that particular purpose?
Rosa, do you want to comment on that? Whether we should age into robots or focus on older age? What do you think?
Well, I suppose that depends on the necessity, of it. I suppose, in some years' time is when we will see, as you were saying, how the numbers are increasing, and how we are, in general, all aging, and what is the workforce availability, and what as cities are growing more and more, and there is less people living in rural areas as well. So I think it's a question of analyzing the situation and what is more important. Obviously, what I see anyway is that in architecture, because of sustainability issues, the trend is going to be not to build things anew, but to rather reuse buildings, existing buildings, the building stock, because obviously this is what is going to be less polluting. So retrofitting is a huge part of what we are teaching in schools of architecture right now. Obviously, each country has different typologies. The UK has a very particular typology. As I said, for public buildings, it will be easier. It will be much easier because of because you need a space and how you can control the space. For houses, it will be more difficult, but if it needs to be, we will find a way to do it. I'm pretty sure. And as I said, what is very interesting about what we are doing today is that we are starting the conversation, which I wasn't aware of this at all. We certainly don't teach this. We don't have it in any regulations. But if this is coming in the same way we are currently reviewing standards for becoming more inclusive in any possible way. And normally when we think about inclusive design, we just think about physical barriers, but we do know that it's a lot about the senses and other necessities, including the robots. I think it's the right time to start thinking about that, because if this is coming, and as you say, maybe the current elders are not very keen, but certainly my son, who is 15 years old, he's all into everything, machine, screen focused. So I'm pretty sure that he might be, happy to live with a robot. I don't know. I will ask him. But I think it will be easy.
Yeah, I want to add one point that just came to my mind, because Bernadette was talking about this, that some of the people who live in her accommodation, they are logging into an app to get their results, and then they hand it over to the caregiver because they can not work with the interface. And to be frank, it's just a bad interface in that incident, and someone would need to work with elderly people to develop an interface that was working for the people. And on the other side, I think it also, if you show that some technology, if it's robotic or not robotic, really benefits elderly people and they understand how much benefit they have, I think there's so much motivation to use that. And I can give you an example. So in my parents, they are 70 plus. They probably have never used a mobile phone as much they have done now, and certainly not when they were in my age. And living in a far distance to them and being able to to have video calls with their family members who are living far motivates them so much to actually have a phone and to go onto the phone and then use the other advantages that the phone also provides. And I think that can also happen. They are 70 plus, so I'm sure that it can happen with also people who are suffering from other conditions and diseases.
Right. So I just want to pick up on what we've talked about in terms of compliance, picking up on screening, where we don't have 100% of people turning up to screening, even though it's known to save lives. We've got hearing aid use, that even though you've got hearing impairment or hard of hearing, you won't necessarily use a hearing aid. And so I just wondered, is there actually lessons that we can learn from how the older population may view some of these, where the evidence behind it is really strong that it actually benefits you in terms of robots, smart technology and integration? Or are we just innovating for innovation's sake, do you think? I'll come to you, Paul. Have you got a view on that? Do you think it's going to make a difference?
I think one of the, this is just, anecdote from kind of what you're describing, is that a lot of times when this new technology seems interesting, maybe to the younger people, that we could see a benefit. So I think there's going to be there's got to be something where this new technology is crossing generations. So where it's perhaps the child or the whether it's the 15-year-old or where they're able to kind of convince the older people that this is needed or this could help. But and you were kind of alluding to, should we be kind of aging into this? Maybe should the focus be on having robots help people who are not elderly, and then maybe when they're elderly that they'll be used to it more. So, I mean, new technology is, I personally sometimes don't want to deal with new technology, so I can appreciate the challenges here.
Anyone else want to comment on that?
I think, as I said, a roboticist or an innovator, you need to leave them in their dream to develop whatever they want to develop and have their dream of a fully autonomous system that take care of humans, take care of a full autonomous operation, etc., in order to advance the field of robotic technology. And of course, some of this is not viable, doesn't make sense for applications in certain areas, maybe in an area that we are talking about. What I think is that some of the innovations that come out of these labs might well be a very good solution for the problem that they need to solve. And I think there is this coming together of just fundamental research in the field of developing new technology and robotics research, and combining that with, on the other hand, the elderly people or the caregivers to then come together. Okay, now do some cherry picking, essentially. This is what I would like to have, and this is what I like to have. And I think that really makes a benefit. But, the other thing that you are proud of, roboticists, that is not really working for me. And that's absolutely fine. But I think there needs to be both of this happening.
Brilliant. So if I now go on to sort of like training and education. So I'm talking about education within disciplines. Rosa picks up on that a little bit. And training on use, if implemented, would appear to be very, very key in terms of acceptance, integration, and design of assistive technology. But with this, say, from the resident's perspective, may also create fear of not being able to use the technology or manage, or if it was with the caregivers, the training required. So I'm just going to pose it to the panel. What do you think are the main educational and training needs? And is this truly manageable and sustainable if we were to integrate robots and smart technology? Yes.
Yeah, can I say that I haven't been enjoying how we're talking about older people? They're not elderly, they're older. It's not a different category, it's a continuum. And I think older people are like younger people, but they're a bit further on, and they're not completely different. Now, one of the things we saw, they were talking about the pandemic. During the pandemic, there was a mass take-up of people learning how to do video calls. And that was both older people and actually younger people. We all started doing it lots more at work and have kept doing it. People can learn, not if they have dementia, they're not very good at learning, but other people can learn if they're older and will learn if they think that it's advantageous and interesting. So you're quite right, you have to work with people and see how do they find it friendly and intuitive, and can they see how it is, how it's useful to them. But they will. People will. If they don't, the problem is the way that we're messaging. It's not that older people. I mean, I've been watching the audience, and there's all these older people in the audience, according to the way that I can judge. I don't know anybody. And they're sitting there on their phones, and they're sitting there on their technology. And we used to think that older people didn't use it, but they do. So I don't think that there's a problem about that. I think the problem is that we don't know it's any use. That's what we've got to come over. What do we want to do it for? Because there's many, many, many different ways you could use it. Is it useful? And is the use worth the cost? I think the answer has to be some of the time. And the difficult thing is to do the biomedical research, the robotics research, to find out when it is. And maybe it won't be useful for people with MND. That's possible. But it's a very small percentage of the population. It'd be nice if it was, but nothing works for everyone. And uptake is never 100%. If you begin to say only 70% of people are uptaking it, are we innovating for innovation's sake? We'll end up knowing nothing. There's been a huge change. That's why we're all old now, because things have really changed, and I think they'll continue to do so.
Bernadette, do you want to come in on that in terms of learning new things when you're at the stage of a hospice and at home?
Okay, right. Just this week, one of our cancer patients, she needed steroids, and that's given her a new diagnosis, steroid-induced diabetes. And her blood sugars are up and down, and she's about to go home. We contacted the district nurses. They could go in morning and 5 o'clock to monitor her BM, her blood sugar. But the diabetic nurse at the hospital rang us and said that she could have a Libra, a white gadget technique, applied to her arm, and that would display the blood sugar reading onto her phone. So that would save the district nurse coming in. But in order to do that, the diabetic nurse will send the patient several videos to watch, to learn how to set it up to her phone. So she can't do that, but luckily her husband will be able to help her. So we need, training materials for the patient and relatives. So if part of the solution of the workforce crisis is, we keep saying we need to train more doctors and nurses and physiotherapists, and there are fewer people around, fewer people wanting to do that. So we'll have the robots that can help with the care aspect. So we need to train more engineers, or we need some engineering skill in the hospice if the robot doesn't work that day.
Melina, has anyone put in any questions at all?
Yes.
Do you want to ask?
Yes.
Well, we've got about 4 minutes.
Yes, we have 4 minutes. There's an anonymous, I don't know who asked the question, but is the robot replacing human connection?
I'll address that to our roboticist at the end. Is it replacing human connection? The robot.
I think everyone needs to ask themselves, do they want to be disconnected from human interaction when they are older than today? And I think for me, I can say I don't want to be disconnected. So would I be motivated in the future to just use a robot to have this interaction? I probably would not. So I think that a lot of other people don't want to have this replacement, and that's why even developing a system that would replace a human in this interaction, no one would buy it, I think.
Have you another question at all?
Kevin, are you here?
Very quickly.
I was curious about
I was curious about the potential for AI in robotics and care for older age, but the potential, the timelines, any low-hanging fruit. Obviously, there are some regulatory concerns, I imagine, as well.
I think maybe I answer that one, and maybe someone can follow up. I think AI is in many of these technologies tools, starting with your phone, and then of course it's used in language processing, answering, etc. So it's already happening. There are concerns, as you know. One of the big car manufacturers from the US has major problems with generative AI tools, as you might have heard today's news, and this will keep on happening until we are addressing that field of how can we have responsible tools, and how can we make sure that this is happening from harming people, right? And then there's, of course, the data protection side, etc. But in terms of personalization, I think these tools can play a major role.
Great.
It's already happening, I think. The question is, who is funding this in care homes? I think Bernadette was saying that they don't have a device that is...
Well, in the healthcare, AI is used in, pharmacology. You have your genetic profile to predict which drug you will respond to or have side effects. And AI is also used in precision genetics and lots of fields in medicine already.
Brilliant. So although it would be great to have some follow-up responses and questions, we've now reached our time. So let's thank the panelists for a very entertaining.